Hey Barry, hi Rich, how you guys doing?
Hi, Mark. Doing
Hi
well.
guys.
Hope you guys had a good
R-
week. I know you guys had a great podcast, and I'm happy to be joining you guys this week for our weekly podcast. Um, I think maybe what we could talk about is, the textbook on airway-focused dentistry, looking beyond teeth, gums, and joints.
hmm
And, I have to say that I'm very excited because, as we've been teaching these courses and really trying to provide a template, an intellectual construct, if you will, to understand something that's rather complicated that has been tended to be simplified by weekend courses that are device driven and technique driven, that I'm really proud of the work product that's been the course of the last 2.5 years with a number of other authors. And I'm super excited because it will provide the profession, both medicine and dentistry, really for a good construct because it is truly interdisciplinary. It's a compilation of a dozen or so providers from both medicine, dentistry, and allied health. And I was saying in the green room as I was editing the chapters, getting them ready to push them forward to a staff review at Elsevier, that you know, I've had several moments this weekend where I'm sitting back and thinking, wow, you know, this is really organized. This is really well documented. I think it's really logical. I would love to have a book like this to read. And it's not until you go through this process that you understand that. So let me just say, I'm really excited about that. So no hyperbole. So anyway,
Well, I enjoy the hyperbole because it really is a compilation of all the years of experience, all the research that's come out now. I mean, I got a paper today about the relationship of mastication and respiration in cognitive function. It's a literature review, and it pulls together just like we're trying to do, and we are doing the threads of evidence from various lines of thought, various disciplines, and is pulling together that understanding that we have of the body as a whole, the underpinnings of that such basic physiology of breathing, and how the downstream effects can be both significant and underassessed because they are so far down the stream. And I think we're going to do a good job of putting that together for people, really connecting the dots.
yeah, I um, well, I have to say yes, that's good. But I was also preparing, Rich, for our AMR 3.0, our part two, the follow up to our very successful first part. And the preamble to the textbook is a guide to practice of the airway focus. And so I write down the four sections of the textbook so that the reader could kind of go through in an organized fashion and understand it. And I actually um, printed the chapter, the preview chapter, and just to kind of read it to you, uh,
Yeah.
because I want to include this in our syllabus. I'm going to send it to you because as I'm reading, I'm going, wow, this is really a good way for the student to really think about it. And it's basically how to use the book, and it goes over, the practice guideposts, which we've talked about. One, the medical indications for dental interventions.
hmm
Two, the anthropological standard for craniofacial airway evaluation. 3, the triad of structure, function, behavior. And
Yep.
4, looking at breathing versus as a focus versus just sleep. And the structure of the book goes section 1, chapters 1 through 6, is basically the intellectual context for what we call the airway health paradigm. It kind of describes, well, what is airway health? Because a lot of people have their own ideas, like it's, MMA surgery or skeletal expansion. That's not airway. That's a technique. Section 2 goes into what's at stake, goes into all the medical comorbidities,
Mm.
um, daytime, nighttime, that transcends really, the dental domain, if you will.
Hmm.
And then section 3 is screening and diagnosis. It's chapters 13 to 18, how to actually document quantitatively and qualitatively. And section 4 is the intervention tool chest with appropriate sequencing, which is super exciting because once you understand the problem, you understand there are so many things we in dentistry can do beyond dealing with the direct dentition and occlusion, even the joints. And that's chapters 19 to 26. And um, anyway, so um, I'm going to send it to you because I think it's going to be something that you could put in the syllabus that you've already put together. It's brilliant, really, as maybe a way for the student really to think about it. So I'm going to make sure after the podcast, I email it to you so you can kind of look at it and see if it makes sense. And you as an educator, as a world-class educator, can really look at it and see how you would integrate it in the syllabus, really to make it easier for the student at whatever level that they're in, to really understand how to immerse themselves and not get lost, to be able to on Monday be able to start seeing things that they didn't see before without disrupting their practice. Because I think it's really important. Our audience are really practitioners, not academicians.
Right.
They have to make a living doing this. And
That's right.
it's really tough on Monday after the course. You want to talk to everybody about airway. That's not the thing that we want to do.
Right.
Right.
No, I think I'm really looking forward to it, and I'm looking forward to the integration of the textbook with our courses. And I remember when I was a student at UCLA, I remember taking a history course, and the professor who taught the course wrote the book. And every week we went through one chapter. He didn't say it, but the reading assignment was one chapter a week, and there were 12 weeks in the quarter at UCLA, and so you could do the entire book in one quarter. And I remember thinking from a teaching standpoint how brilliant that was, because you really knew where we were going and where we came from, and the way he utilized the lecture time to bring in the stories and relevance and making sense of the complexity of the chapter without having to actually refer to the chapter. And I just was it just was amazing. It was one of the greatest courses I've taken. It was in history, and here I am in dentistry. So I think that this will serve as this beautiful rock that we can rely on, that we can sometimes assign reading assignments from, that maybe a little bit allow people to get more into depth if they wanted to. And everyone learns differently. Yeah. So there are those that are just not, it's just not going to be what they need to practice at their optimal level. They don't need to have that. Others do. Mm-hmm. I just finished a course this week too at our teaching center, completely unrelated to, well, no, it actually was very much related to airway, because what we interjected into the course, well, thanks to you, Mark, I'm changed forever. I can never teach the same again. But some people take notes, some people listen, Some have got their computers out and they're doing notes with the keyboards versus with their pens. Others are just staring at you, and just how everyone has this different experience in putting all this information into their heads. I'm just beyond excited. I really, this is something that I think is going to be great for us. So yeah, when does it come out, Mark? I mean,
Well, it's yeah. So it's up to Elsevier. A lot of it's getting. The thing is that I've learned in doing this project is it's super complicated. At least when working with Elsevier, who's at the top of the food chain as it pertains to like
for sure.
academic.
Yeah.
They're very very robust in how they do things at the top level. So you got to get the permissions, and then of course the artwork and all that. And so that's mostly really the variable at this point is them reaching out for permissions for each of the images that we may borrow. And I don't know how long that takes, but as I was working through it, I was really excited because putting myself as a student, for example, the section on bruxism and constricted envelope of function, and the evidence that kind of blows that all up very logically and very well documented to where I think that my mentors or people that might challenge it, if they read it, it would be done in a very non-threatening way to say, let's just kind of walk you through and put it together in this context of what we really know physiologically, what's going on. And so a lot in dentistry, what I've come to understand, and really from the very beginning, I was very unsettled with a lot of things that were incomplete answers that I had to work through. And you find out what it is as a healthcare provider. We all have gone into what we know now, all three of us having practiced at least 40 years, that you look back and you realize that from when you first started and all the courses in the CE that you sat in and listening to all these, thought leaders and respected KOLs, that there was a lot of information that was missing, that we didn't question, that we just kind of filled in and assumed. And I think we always practice with that level of uncertainty. But what I liked about this book is it acknowledged it in a way that I think allows the clinician to think significantly different than the way we were trained in a disease management healthcare system, looking beyond the signs as diagnoses and seeing them more as findings. That there is really this upstream process that begs the question why. That we're just not really trained so much to look at why. We're just trained to solve problems. We've got a white coat, patient comes in, they're in pain, and we solve their chief complaint without really having that much attention given to the why. And it's not a right or wrong, it's just kind of an is. And I think this textbook really takes a deep dive into that whole process. So anyway.
No, I think that's amazing. It's going to be it's going to be a hot topic.
Yeah.
It is going to be a hot topic. This book is going to be looked at really with a lot of scrutiny, a lot of different people. People are going to challenge things. It'll be reviewed all over the place. The big dental journals are all going to have their people read it and write about it, and it's going to get a lot of attention, no doubt about it. I mean, my God, if you think about, like, take a topic like dental erosion, or recession, clinical attachment loss, and things like this we see all the time, and we think we kind of have figured it out, sort of, and yet airway trained people see it very differently for a whole bunch of other reasons that you would never even consider. So we understand it differently. But there are people that have based their whole professional lives on writing books about it, and one chapter might very well flip a lot of these, these,
Concepts on their head.
yeah, exactly. And
Yeah,
so it's really going to rattle the dental academic community, and I hope that like you've experienced, Mark, when you've lectured, some of these icons and some of these people that are known for certain things have actually come up to you and said, "Hey, Mark, I think we might have got it wrong," and that's beautiful. And I hope a lot of that happens. Who knows? It's not going to slow us down if they don't.
Yeah, no,
but I think
right.
yeah.
You're right, and I think here's the difference. Is that what this process has really made me understand is that as a dentist, we are really focused on a very, very specific domain of the human body, as if it's an isolation. And you look back and physicians do the same thing. The cardiologist really doesn't look at the other organ systems. There's 7 organ systems, and it really doesn't care, right? Because they're trained to learn so much about the local diagnosis versus like the regional or global diagnosis. That's just the way the system is set up. And the difference in this, I think, that the people who might read and criticize the book, that go in there, I think they're going to have a really hard time if they're really open-minded to understand that the perspective that they may challenge, they're going to have to really educate themselves and understand what they missed, because it really steps way beyond dentistry. Why I feel good about it is because the world-renowned authors that are contributing to it in medicine kind of face the same challenges within medicine, and they will say the same thing. They have the same frustration. So, the ENT that all of a sudden is really respecting what the dentists, our domain, understanding the role of the nasomaxillary complex, that is a complex beyond just the nose that they look at, as an example.
Right.
And so I think, people who are going to be reading it have to be very careful that they don't continue to keep themselves really restricted to just what they know. Because as Mark Twain would say, it's not what we don't know that gets us in trouble as much as what we do know that ain't so, right? So there's this big domain of the known unknowns. So I'm hoping that people, as they read it, will be able to address those known unknowns. And the book has a lot of those chapters covering the known unknowns of the dentist that they just weren't trained in, that came from physicians. But the book is integrated. It's not just separate chapters, it's all integrated. All the authors are kind of singing from the same page, looking at systems biology. That's the difference. The backbone of the book is looking at a systems approach, which is very different than the way we were trained.
Absolutely.
Yeah, it is an eye-opening experience to see a common underpinning to many of the symptoms and conditions that dentistry has been treating for many, many decades, and frankly has been confused about. TM dysfunction is a great example.
Sure.
Dental destruction is really another example. Angle classification is another example. Anxiety, neurocognitive problems, hyperventilation, poor sleep. And yet now that we open our mind to the holistic way of looking at the problem, we see each of these as having a common underpinning, and it makes so much sense. And and it is one of those things we say it on the podcast all the time. Once you see it, you can't unsee it.
Yeah.
But it gives you a clearer vision. We are taking a step backwards, looking at, using the elephant metaphor, we're looking at the bigger animal by stepping back. And I know it's hard for dentists that first get involved in this, because as soon as they walk in, they want to know the how. How are we going to treat this? What appliances are we going to use? What techniques? How can I incorporate this into my daily practice? And we say this right from the beginning. It's not so much the techniques. In fact, we don't really even hew to a technique. It's the change has to come not from what we do with our hands, but what we have between our ears. It's a very different way of thinking about these things. Absolutely. And but it does, once you get past that initial Zen fool's moment of the shock of seeing that everything you were taught seems to vanish before your eyes, that we develop an underpinning way that teaches you how to think about these things in a very different way. It really is. It is very exciting.
Yeah, and I'll add one other. Let me just call it the fly in the ointment, that is typically not addressed in most academic books, but that each provider, whether you're in medicine, dentistry, especially today, ails with, that they complain about. And I mean, I was even talking to my gastroenterologist last week about it, and it resonated with him. And that is the system, the payer, how you get paid. And what's happened is, very quietly, the third party payer has captured the professions, health professions, and really hijacked it away from the provider, where you're kind of hypnotized by the day-to-day coding, how you get paid, and the patient's expectations based on the insurance pay.
What will get covered and
What will
what
get
won't.
covered and all that. So, as an example, in sleep medicine, and the book goes in depth into this, with a science-based approach from the history of how you score, sleep studies, and how that's changed through political means, through meetings, scientific sessions, where the third party payer had a lot of influence. And so all of a sudden, everyone is recanting the evidence based on the context of what the third party payer is saying. Like, for instance,
It's
an
permissible.
apnea, scoring an apnea versus the respiratory disturbance index versus non-hypoxic. And there's a lot of confusion there. And if you don't really understand it, you gloss over and you just kind of go with whatever the insurance says, for example. I'm proud that the book goes into the history and it kind of explains it so that the reader really understands and can regain control of the facts, if you will. And then the other thing is, it goes into how to do it, how to put your team together, and then how really to set up the practice to be a doctor versus a mechanic. And so bottom line is, we all came into healthcare, whether you're a physician or a dentist, to take care of the patient,
Yes.
knowing that if you did a good job, it would be rewarding. It would be, the patient would appreciate it. It'd be noble. But it's changed. It really has changed a lot. And now it's gotten to the point where we talked in another podcast, where it's now transformed into, say, in dentistry, the DSO, that's reduced the young dentist, down to an employee
Procedures.
where work-life balance really reigns instead of the outcome for the patient. And the patient, as long as you know the insurance is covering it, they know no worse, right? And so the system is broken. And I think this book addresses that anyway.
And it is broken from both sides because the patients have been trained to want to pay for only that which they don't have to pay for. You know, we're paying our insurance premiums, but if insurance doesn't cover it, patients don't want it because they really believe that if the insurance company says that it's not covered, that it's not necessary.
Right.
And you know, money is precious to everybody. It's not so easy to afford some of these off insurance or out of network things. They also have to go through, and the culture has to go through a change in looking at what's precious to us as people, as humans. We all say it, as long as you have your health, you're good. And yet we don't want to spend money on our health as much as we want to spend money on lattes and cars and vacations. And it really has skewed us to kind of a dopamine satisfaction rather than a serotonin deep feeling of wellness and health and well-being. I mean,
And yet,
it is a cultural problem as well, in the larger sense of culture than it is just our medical dental orthodoxies.
and yet the irony, Barry, is that our healthcare costs nationally are twice that
Right.
of any other country, and it's bankrupting us.
And we're paying
And,
premiums.
and we're getting sicker
Yeah.
at the same time. So that's why this book really addresses the underlying problem. I have to say, I think I've already told you this. At the end of the um, meeting last year, the American Academy of Restorative Dentistry, the president of the ADA comes up at the business meeting, kind of talks about what his initiatives are in representing the profession. And he stood up at the podium this last year, basically stating it was about airway and really bringing that to the fore.
Hmm.
And so I talked to him afterward, and that led to us setting up a series of meetings to really address the problem. And in the end, what happens is, that the ADA is really a political institution representing the profession.
Mm-hmm.
And as well-meaning as it is, there are stakeholders, and those stakeholders have conflicts of interest with what we do in dentistry, in that they're supporting the ADA because they're going to be sponsoring money to represent their corporation or their needs or whatever. And so I ended up backing out because the meeting that now you can go to and the it's on the ADA website on Airway is still business as usual, which I don't want to be a part of. And he was kind of upset that I was not satisfied with it, but I kind of explained it this way. I said, you're inviting the wolves into the
And house.
into the hen house. The stakeholders that don't want to see it change, that their opinion will be that they have to use their device or they have to take this approach. And what I was saying and appealing to from the very beginning, I said, we have to strip it down to just us doctors. What are our challenges? And so I think that's what I think this book will maybe really challenge that. We'll see. But it's not an easy problem to solve because our population has been so conditioned to expecting the guy in the white coat to come up with a commoditized service that takes care of them for the rest of their life at a low cost with very little out of pocket.
Mm.
And there's no easy solution in dealing with these problems. And the earlier you catch it, the better the quality of life, the less expensive it is. And so anyway, complicated.
Yeah. Well, it brings up the topic of behavior change, really. And I know that a lot of physicians don't, and certainly dentists, and really certainly orthodontists, don't want to get involved in having to deal with patient cooperation or motivation or change of behavior at all. And yet there have been a couple of examples in our culture where people have changed their behavior dramatically in the name of good health. One of them was how we let go of smoking as a cultural norm.
Mm-hmm.
And when I tell stories,
look what it took. Look at how big that battle, how many millions of hundreds of millions of dollars was spent, and how much time it happened over what, 2 decades?
yeah, but it happened fairly thoroughly. Not that people don't still smoke, but I
So
tell the
what
story of
happened,
my
Johnny?
father, the orthodontist, who was smoking in the clinic with
Yeah.
4 kids in the chair in a small room.
And this
He
is
would,
after a 2 martini lunch, right?
yeah, he didn't even drink.
No,
He
no.
would complain that he would light up a cigarette, put it in the ashtray in the lab, go out and treat kids, and he'd come back and the cigarette was spent, so he'd have to light another one. And he went through a pack a day in the office.
Wow.
We used to smoke on airplanes and trains and in closed spaces.
Crazy,
We used to
crazy.
smoke. All right, that's one.
Okay, so what
But all
happened?
right, now, no, but
It
let me say
morphed,
the other,
it
because
morphed
this
into the
one,
food. It morphed into the food industry because those same
well,
chemists
right, they took
now
the chemistry.
hijacked the food. So it
Right.
metastasized to another
It
organ.
went to Doritos. That whole philosophy went to potato chips. But the other one is the prevalence of gyms, workout facilities of all sorts that have sprouted up. They're all over the place. And there are people there all the time on treadmills and machines and Pilates classes and, all kinds of things. This is a huge change in behavioral attitude about how we take care of ourselves. And if those two examples hold any model of what we're trying to do by having people care about their own health and wellness and trying to achieve optimal wellness, I think we're on the right track. Maybe a third example is all I was going to say biohacking, but all of the consumer-based, monitors, the Apple Watch and the apps on the phones and
Wearables.
wearables, nighttime sleep monitors and all kinds of things where we're trying to hack our own biology.
Mm-hmm.
And there's that growing sense of what can I do to help myself? Now, how do you get that across to a 5-year-old child or a 10-year-old child? That's another challenge. But, there is precedent for that too. Parents, they'll always ask me, how do you get the kid to wear that mouthpiece? The myofunctional mouthpiece. I say the same way you do to get them to brush their teeth. You do make sure they brush their teeth, don't you? And they go, oh, yeah, of course. Well, this is really no different. Parents do have to exercise some control over what's going on in their children's health. Certainly the parents that get attracted to our offices are. I mean, they are switched on. Many of these moms know more than I do about certain areas of health and wellness.
So let me jump
And
in and ask, Ask Rich, and all really good points, Barry. I mean, it's the challenge in airway.
Yeah.
But I like to ask Rich, you've been an educator giving these courses, high level courses to, for years now. And, what has been your challenge in giving these courses, knowing what you know now, where, you're talking about occlusion or implants or veneers and prep design and talking about birds. Tell us a little bit about how that's changing your thinking and how you're teaching and how you see the future as an educator and a
Yeah,
clinician.
thanks, Mark. I mean, that's such a great question, and this is our year of massive pedagogical pivoting. We are not ever going to be able to teach because my associate, who's an airway graduate and he's taking the airway courses again, he and I both agree that there's no way we can teach the business as usual. Every course has to be modified within the context of why things are happening. If we're talking about diagnosis, I give the example of recession or something, or maybe a non-carious cervical lesion, and yes, of course, entirely multifactorial and all this kind of thing. But we think that just saying the word "it's a non-carious cervical lesion" is a diagnosis, and where we airway thinkers would we looking at, but why did this happen, and why is it that we see huge amounts of recession on patients that have no true biofilm related disease, and then it seems to kind of settle and get to a point where it stops.
Oh, you're brushing your teeth too hard.
Right, and then all of a sudden they stop brushing their teeth too hard, and it's no longer a problem. And it's just so the course we just finished is really interesting because it's the first course of a series of 7 where we're looking at diagnosis and treatment planning. And can you imagine, Mark, talking about diagnosis and treatment planning with what you know in the way that we were taught in school? I mean, or even in the way that a prosthodontist is educated in 2026 at the highest level of understanding of quote unquote diagnosis and treatment planning of occlusion and why things war and how to. It's all very focused on instrumentation and preparations and materials and cements and glues and aesthetics and photography and reading the literature and all this kind of stuff and all this a massive amount of work that's put into all of this, and they're completely not considering
Why it happened.
any of this. So how in the world am I able to teach this? And I got to tell you, I'm sure we're making some mistakes, and some people are just looking at us like, what in the world is going on here? But I don't care. I know what I know, and and there's a lot of things I can't articulate or don't have enough experience with. So in a way, it's kind of good because I'm making the journey just a few steps ahead of sometimes my students, and we're having this massive amount of joy with all the discovery and the potential. And I'm not afraid to be provocative. I'll throw things out there. I'll say some things like what Barry can say. And he can say them because he's treating thousands of patients. But I haven't treated thousands of patients with straightening and, are dealing with airway issues because of and the parents are thinking the crooked teeth is because they got it from their mom. They got the large jaw from their dad and the large teeth from me, and this is why they're crooked, and they all have an explanation. And, for me to say things so provocative, like if you're treating your patients today with Invisalign and you don't know why their teeth are crooked, you're going down a slippery slope that may, in fact, in the near future, be considered, not standard treatment, and they're like, what? Because everyone's doing Invisalign. So I say a lot of things like that and many different aspects of, what is, general dentistry. And The course evaluations just came in today. It was a 10 out of 10 from every, we had 22 people in the course. We got solid 10s on every category. I mean, they absolutely loved it. We didn't, not a lecture was given without some reference to further thought, deeper thinking, more information will soon be revealed. Keep coming back to what we're doing here, because we're going to help you understand this, and we're steering people towards airway. And so, at the lunch sessions when we're talking to everybody, we're having our sandwiches and salads and stuff. The buzz is all about this disruptive teaching style, where people are going, wait a minute, what is this all about? I mean, you're saying this, is this really what's happening? I'm like, absolutely. You're going to have to circle back and take more courses. But, the course I dread is actually next month. It's on occlusion. Can you imagine teaching a 2-day occlusion course today and not even in the way that we all learned from the masters, and we all did. We learned from the masters. We got really great education, Mark. We learned from, the guys who made the instruments, who techniques are named after them. The legends are all our mentors. Yeah. And now I'm going to walk into a room and teach occlusion. I mean, I can't do it with a straight face, if you know what I mean. I'm going to have to say, guys, we may never teach this occlusion course ever again, because I don't really, we're trying to find a way to teach the parts of it that are important to understand. Because like you always have said, Mark, and Barry, we still have to deal with teeth. I mean, in the end, there are teeth that will need to be restored, and they should be restored properly. So we're going to have to understand things continue to understand things at a high level. But man, Mark, woohoo! If you were a fly on the wall in our course, I think you would have really enjoyed.
And you know what? It wouldn't surprise me, Rich, because as I'm listening to you last weekend. As you know, I was in Portland for executive council meeting for the PCSP, and one of the people on the council was also past president of the PCSP, Roger Lawton. He went through the Airway mini residency some years ago. Barry, I'm sure you remember it.
I do.
And we were at dinner talking about it. He's a super well respected prosthodontist from Washington. He practiced in UW,
sure.
And he moved, and now is teaching. He moved to Arizona. Now he's teaching in the new dental school, the A.T. Stills Dental School, and he says, I just can't teach the same way. I'm in there in the clinic, and I see airway. As a prosthodontist, he said it completely radically changed the way he sees everything. Yeah. He says, it makes so much sense. And the hard part is the how it butts up against the orthodox teaching.
Oh, absolutely.
The training. Mm-hmm. And how do you get, these, we say kids, these young adults that are in there, very eager learning, and without confusing them. And that's a challenge, because it's a lot more complex than, treating cusp, height, groove, direction, right? Gnethology. I mean, that's pretty simple. Really, dentistry, when you make it very mechanical and anatomic, you could simplify it to be able to put it on an instrument, for example, and totally ignore the software, if you will, the upstream why. And so I was listening to him at dinner last week, and I was kind of smiling, and he was kind of smiling about it. And there was another colleague, who's a prosthodontist, was saying, wow, he was all over it. He says, I need to know more. So I think that's kind of where we are, because it's not like it's crazy. It makes sense when you start talking about it, right? But it's complex. And so I think you, as an educator, I could see, knowing what you know, having the curse of knowledge, it's going to be a challenge to continue to teach technique, but always challenge your students on always asking that question, why?
Yeah. That's exactly right.
Yeah.
And also, I was thinking a lot about, if I were back at UCLA and had this knowledge, I'd really be, I would really, uh, I'd be in trouble to a certain extent because, to get everybody, you have to rally people together, and there's so many little fiefdoms all around, everyone trying to protect their own little
Yep.
curriculum and their money and their faculty and the way they teach students and curriculum time and blah blah blah. And there's so many forces, and oh my gosh, you everybody waiting to have a meeting with the dean would be looking at who's walking out of the dean's office before you, and it would actually influence how you spoke to the dean. Anyway, it's I you're it would, I think the process is going to take a lot of time, and it's going to be bumpy at times, and I worry a little bit about there'll be misinterpretations. My gosh, just even how to prepare a tooth for a class two composite or amalgam or whatever. So many differences across the country and schools of thought and instrumentation or whatever. So, I mean, I see this as being potentially vulnerable to that. And that's why, circling back, the textbook will serve as a beacon of consistency, and others may say, hey, I feel this way too, but, you guys published it first, so it becomes the source. And I think that's pretty huge. I don't know if you thought about that when you made the decision to write the textbook, but this is the only way I think it'll actually it has a chance of putting forward a message that can be teachable, understandable, and hopefully keep big corporations out of it as much as possible. That worries me a lot. But
Yeah, I mean, I think,
and by the way, not to say that big corporations are bad, because thank goodness, I mean,
yeah,
our dental manufacturers we're so grateful that in such a small market, dentistry is a very small market, very small. We're just nothing. Our entire, what is it? Our gross revenue dentistry is kind of like the operating budget of the Mayo Clinic. And we're like even, and yet we're just the entire profession compared to one hospital. But I just fear for the purity of it, and I hope that it doesn't, um, you know, become the victim of profiteers and poor thinking and dumbing things down, because it's not something you can really dumb down.
well, I mean, I think that's always a risk, but I think the difference here, and there are two other books that I know the authors, and I looked at the chapters that are it's still very orthodox. I think it's very different than what we're writing, and I think one of the things um, that's different is we're not telling people what to do. The book is really telling you how to think about it, knowing that it's going to evolve over time. I think the problem is when you come up with a book and say, like what you just described, University of Michigan versus University of Washington or UCLA or USC. This is the instrumentation. This is how you prep a class two compound, as an example. Same thing with occlusion, right? And based on their in vitro studies, this is different in that it's really a guide to how to think about the problem, where it's really allowing the provider to be the doctor, and apply very solid principles. So the book provides a foundation of underpinnings on how to think about the problem. And it doesn't provide, you know, it provides the bricks, but not all the mortar, because it'll vary from how you think and your community. But I think that's what makes it different. It's not dogmatic, if you will. And I think that's what you need when you're taking a very complex systems approach. There's a folly um, in a systems approach. You can't really teach a prescriptive way of thinking about the problem. Whereas our current system is very prescriptive. There's this symptom, you could, you know, differential diagnosis in these medications or whatever the case may be. This is different. So,
Well,
be that
Mark,
as it may,
that's a great thing. That's a beautiful thing about the book, then,
yeah,
because it it's less likely to come across as a technique manual.
yes,
It's
exactly.
more likely to come across as a sort of an stimulate the great minds we have in dentistry to
Mhm.
perhaps improve upon some things
Yeah,
and innovate. And that, I think, people would wrap their heads around, and embrace. So that's great. I'm really glad to hear that. You do, of course, show examples of how teeth cases got treated,
sure,
but it's not a technique manual. Do it this way, or else you're not following my
exactly.
technique, kind of thing. So I think that's great. That's fantastic.
Yeah, yeah, I'm happy about that. So with that said, Richard and Barry, what were your learning moments of the week?
Hmm. Barry, why
Mhm.
don't you go?
So I was given a hint about a young woman who's been practicing orthodontics in my state for a few years who is looking for an opportunity. She wants 2 or 3 days, as an associate.
Hmm.
And people knowing that I am looking to ensure the future of my practice
Hmm.
told me about her, that she's really bright and accomplished and so forth. I got her resume. It looked really impressive. And even in 3 years of hands-on orthodontics, she's gotten involved in a lot of the leading techniques and really shown herself to be a competent clinician. So I call her up and we start having a conversation about things. And she didn't really know much about Airway,
Hmm.
but she said, "I really believe that it is the future of orthodontics."
All right.
Well, so how did she come to that opinion? Orthodontists in particular have stood at arm's length from the airway point of view. Those whose orthodoxies are being threatened by it
Hmm.
have gone out of their way to disprove the relationship between orthodontics and airway.
Hmm.
And and frankly, I told her that's exactly right. Braces do not have anything to do with airway. But despite that, the message is getting to her, and if it's getting to her, it's getting to a new generation of orthodontists who are understanding that what they've been taught is limited.
Hmm.
And there'll be further conversations, but um, she begs to learn more.
Wow.
I thought it was great.
Awesome.
That was a little bit of a light at the end of the tunnel for me.
She wasn't letting her education get in the way of her learning.
Yeah, and,
Wow.
and she's a young woman. She doesn't have a family or kids yet. I said, wait till you have kids, and you're really going to want to know about it.
Yeah, for sure.
Yeah.
How about you, Rich? Any learning moment?
Oh my gosh, so many learning moments just teaching. I'm learning as I teach. I mean, I think that's the best way to learn sometimes is try to explain and motivate, and make complex things simpler and doable. There were just a lot of side discussions about connections, and without even presenting a lot of concrete information about phenotypes and findings. My learning moment was just seeing that dentists are looking for answers. If their provided with some of the little teasers, and I think it's a I'm really going to enjoy figuring out how to teach what I want to pass on in a sequence that makes sense, and in a way that is consistent with our understanding. So the learning moment of the week was just I've got a long way to go, but it looks like it's going to be a whole heck of a lot of fun and going to be really beneficial for a lot of people. And I got to tell you, having my associate there by my side, teaching with me in our little dog and pony show, where I'm talking and then he just like we're doing tonight, and have him completely fired up about Airway-Focused Dentistry, and chiming in, and we're layering things, and people are looking at us, and it was really cool. It was really cool. So I'm
another
just
candle
excited about it. You know what I
shines.
mean? I mean, right, Barry? I mean,
Yeah.
if you hire somebody that is just going to eat it up and get into it, that is going to be a great joy for you.
Yeah, makes me
Yeah.
excited that you have that. I'm looking for that as well. So you're really lucky to have Mood. And it seems like there's been a change from
Oh
the first
yeah.
time he took the
Oh
AMR
yeah.
where he's
Yeah.
now. It's
Yep.
like the light switch went on, which is what we see sometimes.
Yep. Yeah.
So I'm excited about our AMR 3.0 session two. It's in March. I don't know, March.
Yeah, it's a 3-day course, right? And this one's called the stabilizer course. So this one is coming up, and I haven't memorized the date, but it is going to be in March. Yeah, it's March.
I don't know, second or third week of March. But I'm excited about it
Right.
because
We'll announce it in the next podcast. But they can go on. Our site's been cleaned up a lot. My wife's an IT expert, and she's really worked hard on trying to make the site more mobile first, and also easier to use for desktops
we'll
too.
maybe send a QR code. I'll make sure it's on the podcast. But I'm
Okay.
excited because as I've been thinking a lot about it, and it's great the way, as an educator, you're able to break things down and structure it, like you did with the identifier now with the stabilizer. It's allowed me to think a certain way, and I'm getting like these clinical cases because it's really focused on, treatment planning and sequencing and, putting it together. And I'm excited about it and uh, putting those cases together and the material together. So it's all good and well, another hour, another podcast.
Awesome, Mark.
Time flew by. Great discussion. Thanks, you guys.
Yeah, Mark.
And I
Of
look
course.
forward to,
Good to see you. Good to see
yeah,
you, Barry. Um,
Likewise, guys.
it was fun.
and
And
I look forward to seeing you guys next week. And you guys, Barry, you stay nice and warm. You're on the East Coast with that.
Oh yeah, it got up to 23 degrees today. It was just lovely.
Oh boy, yeah, we have to suffer with 80-degree temperatures. I'm sorry.
it's a lot. All
Anyway,
right, gentlemen.
you,
Have a
you
good one.
guys, you guys have a good night. We'll talk soon.
Take care.
All right.